So first of all, I would like to explain what are muscular dystrophies. So it refers to a group, a quite heterogeneous group of inherited disorders that are characterized by severe muscle atrophy, but also muscle wasting. So we have a loss of quantity of muscle, but also the quality of the muscle is reduced. What are the most common types? So one of the most well-known muscular dystrophies is the first type. So under point A, it is Duchenne and Becker muscular dystrophy with 6 cases per 100,000. But then we also have a quite large prevalence of facioscapular humeral muscular dystrophy under D with 4 cases and 2 cases of limb girdle muscular dystrophy per 100,000. And they are colored because I'm going to go more into detail in those 2 types. So first of all, to start, I looked at a systematic review by Leone et al., from which is quite recent, and they looked at non-pharmacological conservative treatments, and they put all treatments in 4 different categories. So in blue, we have the exercise interventions. In orange, we have the assistive technologies. In green, the orthotic devices. And in yellow, the effect of manual therapy in muscular dystrophy. So we have a very large representation of exercise interventions. But today, we're interested in this bit smaller part, which is electrical stimulation. And if we look closer at that, we see that FES and neuromuscular electrical stimulation are not very well represented in literature. Concerning the results, the review and meta-analysis that was conducted showed that exercise interventions, if combined with strength training, did show improvements in functional outcomes like pain management, like strength, but no significant structural changes. And we do see that there is no structural change, but people reported a improvement in quality of life, for instance, which I think is important because even though we don't see the structural changes, we do see that people can take profit of it because they have an improvement in their quality of life. So it's of clinical importance. And it is quite different from what was conventionally thought or historically thought, that exercise or too much exhaustion to these patients is actually causing harm to the muscle. And if we look at the other 3 categories, well, it's disappointing, but the literature is very limited and inconclusive. And this is partly due to the fact that it's very difficult to gather people into a study because there are very few cases. And they are so heterogeneous, even inside one muscular dystrophy type. Moving on to the case presentations, I would like to start with one case about limb girdle muscular dystrophy. There is 2 different categories again, the autosomal recessive type 2 and the autosomal dominant type 1. Then there are even more subcategories that I'm not going in detail, but the main symptoms consist of the weakness in the shoulder and pelvic girdles. There we also see variable findings of signs and symptoms. We see variable age of onset of muscle weakness, and the life expectancy can also be reduced depending on the fact whether the cardiovascular system is affected or not. This is dependent on the type of dystrophy you have. So I would like to talk about a lady, 72 years old, and she presents with severe dystrophy of the paraspinal muscles. As you can see from the slide, she has chronic lumbar spondylogenic syndrome, which also led to spondylosis, stabilization on the spine, lumbar spine, low back pain, a history of hip arthroplasty on both sides, and sacrum and pelvis fractures after a fall in May 2020. For the structure and function levels, so here I listed the muscle strength levels. So as we saw in the beginning on the picture, the muscle weakness is pronounced on the proximal part, or the parts that are proximal to trunk and pelvis. So this is represented in the muscle status as well. So the muscles around the shoulders and around the hip, so gluteus or the shoulder deltoid muscle, the biceps, those are rather weak. And if the further we move distally on the lower arms or around the shanks, they are normal strength again. We see that with her, and structurally we see a hyperkyphosis on the thoracic spine and the cervicothoracic scoliosis. Then we measured SEPs of the tibialis nerve in September 23. There she presented with normal values in amplitude and also in latencies, but only about 5 months later, she had increased latencies. Left were even higher than right. And the SEPs on the somatosensory cortex increased by 10 milliseconds. And even though these 10 milliseconds might not seem like a lot, functionally it does have an impact. So, and this is what it looks like when we look at the gait. So what is apparent is that she has a Trendelenburg syndrome, so dropping of the hip on both sides, which comes from the weakness in the glute muscles. We can see the scoliosis very well in the thoracic and cervical spine, the difference in shoulder elevation. And what is very interesting, that she has no arm swing. So I'd just like to quickly point out why that is. So she actually uses pushing off her legs in order to be able to extend her spine because of the weakness in the spine. So this push here allows her to move more upward. The assessments we use for monitoring the muscle are both MRI or ultrasound. Ultrasound is quite quick to do, but in the MRI, I found it very interesting to see that we have here, if you look at this part, within 5 years of the progression of the disease, we see that more and more the muscle is infiltrated with fat. Through therapy, we have different goals for the therapy. We would like to increase the stability, decrease the functional decline, help with pain management, increase muscle strength, or at least maintain it. That should be the better word in this case. We want to prevent falls in the future and also help her with ADL independence. For that, we strengthen the more proximal muscles, so the ones that are the weakest. By doing stability training, we do isometric exercises, but also moving on to more dynamic exercises in a closed chain. Everything in combination with FES. And for that, we use the parameters of 20 to 35 Hertz with 300 microseconds and intensities above or below motor threshold, depending on how she is on that day where she comes in to us. And we do cardiovascular training using arm cranking exercise, as you can see on the picture. This is what stimulation of the legs and the upper extremity looks like. So on the left, she is doing a simple leg extension exercise where she is asked to focus on the motor control of her proximal muscles. And on the right-hand side, we stimulate the muscles proximal or around the shoulder girdle. And it is a kind of modified plank. So she is not able to hold herself on her elbows like the normal plank you would do. So we put the arms on the side and ask her to push on the elbows. There are a lot of challenges, but the main ones are about choosing the right parameters, because there is no evidence, no clear protocols of what we should or shouldn't use. The current difficulties we have is a lot with muscle fatigue, especially in this patient we see. So we cannot use frequencies higher than 30 hertz, I would say, because she is fatiguing too much in the session itself, and then also coming back the week later and reports of fatigue that was even spread over the next couple of days after therapy. The future challenges she might have is the denervation atrophy, if not already present at this age. So we need to think about a way to stimulate her denervated muscle, especially with the implants, which might interfere with the stimulation. And we need to talk about future possibilities regarding maintaining her gait function. So talking about assistive devices for walking, like getting a rollator, or about a retirement home if she loses more ADL independence. The second case is a case of facioscapulohumeral dystrophy. There are again two types. The most prevalent one is the autosomal dominant one. And they present with a muscle wasting and increased progressive weakness in the face, muscles of the face, the shoulder girdle, the upper arms, and the shin. And they present with fatigue and pain. And again, like the previous example, there is a variable age of onset of this disease. And but most commonly, the progression is quite slow. And as I mentioned, the progression of the disease is from up to down in the most cases. This is a 38-year-old female again. And I notice we have a large representation of females in our case series. Normally in science, they are underrepresented. So this, yeah. And she is using an ankle foot orthosis on the right leg, or she is supposed to use one, but she does not do it due to aesthetic reasons. With her, we try to improve posture, decrease the functional decline, and increase physical appearance. And for that, we do stimulate the muscles around the shoulder, like serratus muscle on the trunk, the rhomboid, deltoid muscle, and the core via nerves. So we use 20 hertz and 300 microseconds. For the biceps, which has denervation signs in it, we use long pulse stimulation and single twitches. So we use 2 hertz and 120 milliseconds. And we use ultrasound imaging to monitor the muscle structure. So on the left-hand side, we stimulate with long pulse stimulation, and this is a frequency of 2 hertz that we used. And I don't know if it was clear in the beginning, but we don't see any contraction in the biceps. We do see that even we put the electrodes on the biceps, but we see the triceps on the other side contracting. So we have a spillover of the stimulation, which means that we should use different parameters to stimulate the biceps muscle. So my suggestion would be to increase the pulse width. And on the right-hand side, it's just to show again that in ultrasound, you can actually monitor that the biceps is not contracting, but it's the triceps on the other side that is actually just pushing the biceps up. We do see skin reactions, so redness of the skin after long pulse stimulation, but also after nerve stimulation. And we found it quite striking to see this color gradient on the arm. So the areas that are stimulated are very much showing redness on the skin, and the distal parts are not. I mentioned posture training. So we stimulate the muscle around the shoulder girdle to decrease the scapular winging. And we also stimulate the core to decrease the lumbar hyperlordosis and combine it with exercises where she is supposed to also contribute to the movement. And as a comparison to the stimulation of the biceps, I wanted to show you that she's actually able to move her arm or bend, activate her biceps. But we also see that quite a big part of her biceps looks highly echogenic in the ultrasound, which is an indication for the denervation. What are our take-home messages? So the main in people with muscular dystrophies in general is to maintain the highest independence in ADLs, so in activities of daily living. And that is also what the stimulation or the training, the therapy you do should focus on. We want to help with pain management. We want to have a biopsychosocial approach. So not only see what the muscle structure looks like, but what does the patient need in their daily life? What challenges are they facing? So also regarding the mobility, elderly home, for instance. We want to integrate FES in their daily lifestyle, so in their daily routines, without accumulating fatigue, and build up strength and endurance to do that, and choose the parameters for FES wisely. The program should be highly individualized due to the fact that everyone is so very different and reacts also differently to the stimulation. And as the study I showed in the beginning, the meta-analysis showed that they did see improvements in function, but not in the structure. So that is also, it was a good message for me to take into practice to look at functional outcomes rather than only measuring muscle thickness, for instance. I think there is still very, very much to be discussed in this matter, but I would be also eager to know if anyone has inputs about this, to know your opinions about the denervation signs in the biceps. Why do we only see that in this very small part of the biceps, or is it only one head of the biceps that is denervated? And how do we approach the problem of muscle fatigue? It has been analyzed that the lower frequencies help with reducing fatigue, but again, is this also true for this kind of population? And are there other parameters that are important? So is it better to stimulate at a sensory level or more at a motor level? What makes sense in a physiological point of view? We don't know what it does at the cellular level, right? And can we project the results of the strength training or exercise interventions, I want to say the frequency of strength training, can we just take over those parameters for our electrical stimulation interventions? I don't think so, but yeah, so there's a lot to still be investigated. And with that, I would like to thank you very much for your attention.